Today we're going to talk about the community response team, but I want our listeners to understand what that is exactly. So will you give me a little history about how that program came to Tulsa and what it is?
I can tell you that we've been in Tulsa since 2017, so we've been in existence for just over 7 years. And how we came to Tulsa, all three of our agencies worked together to figure out a plan to bring a mental health co-response team to Tulsa.
So why was that important?
Let's go back to 2016 when we actually all got together and realized that there were some situations and issues that were not being addressed. So what we realized was that Tulsa specifically is 5th in the nation with the highest rate of individuals who suffer from some kind of a serious mental illness.
Oh man, that's a lot.
Yeah. The rest of that is research shows that only about 15% of those individuals are actually receiving some kind of treatment. So through our partnerships and our work together, we realized that a lot of those calls of individuals that were suffering from a mental illness were actually going to 911. They weren't coming to us as the mental health professionals. So we worked together to figure out how do we partner to get those individuals some help.
I would like to kind of just recognize it was the grassroots where this came from. It was the Mental Health Association. It was nonprofits. It was advocacy groups calling out for co-response models. And they recognized the importance to partner with first responders and not have an adversarial relationship, that we needed to work together. And from that, we got support from the United Way to start a project, pilot project. And from there, we started collecting that data that we needed to show the city council, to show people, look, this is how we can improve services in Tulsa. And from that, we were able to grow. And I really want to say something. Our former deputy mayor, Amy Brown, really assisted in bringing this program along and making it full time.
So I'm sure that you all felt that on the front lines every day. So can you tell a difference just in the last 7 years of the impact that CRT has made?
Sure. I mean, when we look back even at 2015 and 2016, when we were looking at models, police officers were spending hours in emergency rooms with someone in crisis. There weren't a lot of beds in Tulsa. We were tasked with transporting people across the state of Oklahoma, sometimes 3 hours away. And it put a lot of strain on the police department's manpower. And also the person in crisis is not good for them. So we started looking at the problem. It was actually the Tulsa Fire Department and the fire chief, Michael Baker, at the time, who brought this issue to my attention, that we were going to the same addresses over and over again on calls. And we were trying to look at the root causes for that. Like, why are people calling 911 for chronic issues like medical issues, mental health issues, and not utilizing the resources already available in Tulsa? And a lot of times it's because family members don't know who else to call.
Right.
There wasn't a 988 then. There was a COPES at that time, but just getting that out into the community. So when there's an emergency or someone perceives emergency, they call 911. And so we were getting those calls.
Right. So how does this differ from a traditional model? Obviously, a co-response is a collaborative between a mental health professional and first responders, but it goes even deeper than that. Can you just explain that a little bit, how it differs from a traditional model?
Well, the traditional police model, on any call that is a priority call, there are at least two police officers that go on that call. So 2 patrol units. If someone is suicidal, you'll get a EMSA unit and a fire unit. So it was a lot of resources going to someone who was just in a mental health crisis,
right,
and not a danger to the public. So it's very expensive to do. The co-response model puts police, fire, and COPES in the same vehicle, so it's one vehicle responding to the police call. And so even if there are other units en route or there, we're able to release them to go back in service to take.
Oh, that's so
calls.
great. So really, we were one of the very first to instigate the co-responder model in Tulsa. There was one in Colorado, is that right?
Yes. Yeah. The community response team is a unique model. It's not one that you would see in every city in America, even other cities that have co-response teams. And so Colorado Springs was one of the first, which is the area of the city that we went to kind of look at their model. And I think it's important, you can go a lot of different places and see a lot of different models, but you got to make it work for your city. And so through the innovative thinking and some of the planning, community response team was developed. What I like to say is this unit does bring so much value in regards to you are really putting professionals together who work together. Their team dynamics matter in this type of stuff. And so when you're talking about combining a mental health professional with a police officer, with a firefighter, paramedic together, you can leverage their expertise and their knowledge all together and really be a force multiplier within the system, meaning you're able to get those other 911 resources back in service. And there's so much data and research out there kind of being developed and a lot more on the horizon on the effectiveness of these co-response models and how they're really providing a good service to the most important people, and that's our community members.
Yeah, and it's putting the right resources with the right people at the right time, I'm guessing. So really, if it's a mental health related 911 call and the co-response model CRT goes out, what happens? What does that typically look like?
So when we look at what's called a CAD screen, which is where the police and fire calls come in. So we look at that, we pull those right off of there. So we're not dispatched out. We see them, we see if it fits our criteria, we go. The police department's required for safety, scene safety, of course, and making sure that the legal rights of the person are respected. So that's kind of where we go. We make sure everything's safe, and then we hand it over to either fire or to COPS.
I think another unique piece about that is how we operate. And we've, like Justin was saying, we've learned some things from the different models and then what works for our community as well. So that back-end navigation that we've added to our team as well.
Yeah, explain that a little bit more about this navigation piece.
Yeah, so the navigation piece is actually newer with our co-responder teams. So when we went to Colorado Springs, when we brought back pieces of that model, that wasn't one that we necessarily started with, but we realized that it was necessary and needed. And so we've been able to implement that as well. So that means that we have back-end navigation of all of those crisis calls, meaning that case managers work with the individuals after they've been stabilized in order to help them figure out what they need in order to obtain long-term stability. That could be linking them to the right mental health services. It could be helping them figure out where food resources are. We really look at all of the social determinants of health and then meet those needs for them.
Oh, that's great, because that's after a crisis, obviously. You know, you have somebody calls 911, say they're maybe suicidal or something. So CRT goes out, stabilizing in place, taking them to a facility. I mean, how does that work?
Well, yeah, that's something that we really pride ourselves on with these co-response teams, is they're really providing a great resource in regards to, you think of the typical 911 system. Somebody responds, they take care of that situation, and then it's over. And then nobody follows up with that individual. And thankful for Family and Children's Services in this circumstance is that never stops now. Now that individual gets followed up with and make sure that they're getting that assistance that they need to continue that care. And we've seen difference in that staying with that individual to make sure that care gets continued has really helped to reduce some of that 911 usage of some of our most vulnerable populations. And
for calling after a crisis and then calling again, because truly, I mean, even if you're in a crisis, the moment is past, but you're still dealing with the underlying issues on why you're there in the first place, right?
Absolutely. And you said something a little bit ago, and I wanted to kind of go back and talk about it. Some of these incidents, especially that CRT are responding to, these are elevated incidents. You can look nationally. You see these on the news sometimes, and in some areas, they may not go so well.
Right.
And this team here with those individuals, three agencies there, they're able to handle that in a really good way. And I don't know if enough light is shown on that aspect, because these can be complicated situations that cannot go well if you don't have the right people on scene. And that's what kind of CRT does.
They're the headlines basically, and so you're preventing the headlines from happening.
I think that's just a great way to also kind of give another example of that stabilized in place. Because we all work so closely together and because the team is actually linked to COPES, which is 24/7, we can stabilize individuals out in the community and know that there's going to be follow-up done with them. Maybe it's in a few hours, maybe it's overnight, maybe it's several times throughout the evening in order to stabilize them and then get them connected to the right kind of services.
I want to just bring up an example of us responding together. A few weeks ago, we had a individual climb up a tower in North Tulsa, and we responded, and it wasn't just our CRT team. We also had our alternative response team was out there as well, and our integrated response team. So we had a variety of clinicians, trained mental health officers on scene, and the fire department, who they're also CIT trained, crisis intervention team trained. And so we were able to put the team in a fire truck up in the bucket to talk to the individual. And
that included the COPES individual,
the
correct?
The COPES clinician was originally there, and then eventually came down, and it was police and fire up there. But it was actually I keep giving shouts out to the fire department. It was the fighter.
That's why we like you, Shelley.
Who built the rapport with the individual, which shows that's how we move forward. We might be police forward at first and back up. A lot of times people want to talk to fire because they have the medical background. And so we were able to just kind of play off of each other. There's 3 people in the car, and the bucket, there were 3 people as well. And so someone there can build that rapport, and they're all trained to do that.
And that incident ended well.
Yes, it ended within a few hours. And a few years ago, we had someone on a tower, and it was days they were up there, and we had our crisis negotiation team out there. So we had a different response.